Endometrial sampling, a stitch in time saves 9. Let us welcome once again Dr. Neethu Sukesh to take us through the when, why, and how of the timely endometrial evaluation. Over to you, ma'am.
Thank you. So I come again to irritate you people. So this is endometrial sampling. So we all have one patient, many patients actually, who tell us like we have a postmenopausal bleeding or a heavy menstrual bleeding. They'll be like, why to do two anesthesia, doctor? Just get done with it. I just have to remove the uterus and it's done. I don't want a D&C before that. Just do it. You have to give in to their pressure. So I here just want to tell you some reasons why you should not, and some persuasion skills which you can use to tell them that this is not the right thing. So endometrial sampling, a stitch in time saves 9. Endometrial biopsy is a primary basic diagnostic method, and everybody here knows that. So I'm not talking about that. I'm telling you why you should be doing it. Could be obtained utilizing different modalities. To establish the right diagnosis, there is a need for a sufficient amount and adequate quality of endometrial specimen. There are a number of modalities that serve to obtain endometrial samples. So the classic D&C, the hysteroscopy, which will be the best, Pipple, Vabra, Z sampler, MyMock cell sampler. I have never heard about all these things. I know Pipple, Tao brush sap, one device. So whatever, Vabra and all we have. Nowadays, sampling with miniature endometrial biopsy outpatient device such as Pipple is the first choice approach. This is what I am bargaining about today, the outpatient endometrial biopsy. However, none of the above mentioned methods allow scraping the whole uterine cavity. Therefore, it's upon the clinician to choose the appropriate technique for each particular patient. So who should have it? I dare not tell you all those things. I just took it from there. So who should have it? And everybody knows a postmenopausal bleeding, a heavy menstrual bleeding in a perimenopausal lady, a young woman, I would say, with a high BMI. Of course, that is one person you should do a endometrial sampling. I have had to do a hysterectomy for an 18-year-old adolescent girl, so with an endometrial cancer. So never think, always think you should do it. In addition, endometrial neoplasia should be suspected in patients who are anovulatory for long. So cervical cytology results of an atypical glandular cells and other indications for monitoring of endometrial pathology, like you find a hyperplasia, or screening for high risk like in Lynch syndrome. So office endometrial biopsy plays a crucial role in evaluating postmenopausal bleeding. It's a minimally invasive office-based procedure that allows for histopathological assessment of the endometrium without requiring D&C. The advantages: high sensitivity, ease of use, comparable to D&C, it's cost effective. But focal lesions or atrophic endometrium can be missed, or a small or deeply infiltrative malignancy can be missed. What are the contraindications? Presence of a viable or a desired pregnancy, a bleeding diathesis, infection. The only absolute contraindication will be a pregnancy. Sampling can be performed with an intrauterine device in space. Nothing happens. I have done multiple samplings with an Mirena in space. When we do fertility conservation, we put in a Mirena also for endometrial cancer. So we do endometrial sampling with the Mirena in place. Nothing happens. It doesn't get discharged when you do an office endometrial sampling. So what are the preparations? Of course, doesn't need anesthesia. It's just as good as a pap smear. You just have to be more gentle, that's all. But if you want to reassure the patient, okay, you can go on for an oral analgesic or in paracervical block or whatever. It doesn't need anesthesia. That is why you have to do it in the office. Cervical preparation, usually nothing is required. Most of them are heavy menstrual bleeding or a postmenopausal bleeding. But maybe if you're coming with an 18-year-old or an nulliparous or a previous cesarean or a multiple laparotomy patient, so that might be a difficult situation. You can use misoprostol if you want. I never had to use it. 1 or 2 cases where I have not been able to do an office endometrial biopsy. I couldn't do it in the OT also. That was that bad uterus. Prophylactic antibiotics are not necessary during a sampling, not for infection, not for endocarditis. General procedure, basic test steps are common to all sampling procedures. place the patient in dorsal lithotomy, you examine the patient bimanually, insert a speculum, visualize the cervix. Cleaning can be done. If anesthesia is to be used, you can administer it. Endometrial sampling device can be inserted without grasping the cervix with a tenaculum, especially if you're using a Cusco. It just stabilizes the cervix, you can just go in with a pepple. But if it is not, sometimes it's acutely anteverted, retroverted, you can't get the curve. Most of the times, people with an intra-luminal stillet helps. It also acts as a sound. It will be a little stiff. But you're going with a Vabra aspirator and all, where it is little flexible. It might not flex that uterine angle. So that cases, you might have to use a tenaculum to straighten the angle. And sometimes you have to use a sound. Steady and moderate pressure, that's always we say steady and moderate pressure, insert the sampling device, can use and attach a tenaculum if you find it necessary. Usually these have marked centimeters, so you can be sure to measure the uterine depth also. Once it is stabilized, you pull out to create suction, and you have to move in a corkscrew method. You do rotate it and keep rotating and pull it down, up and down. So the suction is what carries the, so you get it from every wall, you just rotate, do up like that. And once you remove the device, you expel the specimen into a formalin container. If it's less, you can go in for a second time. Usually bleeding doesn't happen unless the patient was bleeding from before. But if you have held a tenaculum and there it's bleeding, you can just do ferrix, Monsell or something. So there are two types. The first one, that one is a endometrial suction device, the low pressure device, but it works very well. It acts as a stillet also. As I told, you don't need a dilator. So it's a low pressure endometrial suction device such as Pipel or Endocell, are generally made from flexible propylene and features an outer sheath with a diameter of approximately less than 3 millimeters. At the distal end, there is a side port measuring 2.4 or smaller to collect the sample. The flexibility enables the cannula to adapt to the shape of the uterus, thereby reducing cramping during the procedure. But when you suction, they'll have a little pain. That's it. You have to warn them, yeah, now you will feel a pain. That's it. High pressure devices like are used less frequently because they are generally perceived as being less comfortable for the patient. They are less flexible. Typically, you need a tenaculum. As I told, they are very flexible. So, like tissue aspiration using an air suction pump was first described in 1849, and vacuum curettage by Vabra aspirate of the uterus in 1968. The most popular one would be a Pipel, that was in 1984. So what hysteroscopy would be the gold standard, no doubt. Why? 11% of cases, because of blind sampling, we miss endometrial cancer. Additionally, again 7% failed endometrial sampling. So tissue biopsy facilitated by hysteroscopy improves the accuracy. There's no doubt about it. But we need to think, do you have an office endometrial hysteroscopy? That will be costly. It will be 3 mm diameter, but it will be costly. If you don't have it, as and when you do a pap smear, your option is due to an endometrial office sampling. So one huge meta-analysis evaluated the value of Pipel for diagnosis of atypical hyperplasia. The sensitivity is almost 81 to 99%, specificity is 98%. Accuracy is better in symptomatic patients and postmenopausal patients. And also, and it is better in endometrial cancer compared to atypical hyperplasia. The detection rate was higher in postmenopausal. The Pipel was the best device in both postmenopausal and premenopausal. Due to high adequacy of histopathological specimen, low failure rate, low duration of sampling and cost, Pipel was recommended as the appropriate alternative. The concordance was almost 62% for hysterectomy, and DNC and hysterectomy was 67%. 5% you can just, for the, as you can say, DNC would be the best for endometrial cancer, but for others it works well. But DNC has many disadvantages. What are the problems? You can go in for a perforation, you can have an infection, you can have an hemorrhage. But there are also complications with an anesthesia. You need an anesthesia for sure. And Pipel doesn't need all these things. It is limited capacity for endometrial polyp. When you have a localized polyp, when the suction doesn't work, they don't come. You don't get any cell. So you think like there is a endometrial mass, but you don't get a sample positive. So if you have a suspected focal lining abnormality, the ideal one would be a hysteroscopy, as was already discussed before. So what does the RCOG say? Endometrial hyperplasia without atypia. That's where you go. With atypia, we have a different line of thought. So that requires, they are saying, requires histological examination and an outpatient endometrial biopsy is enough. So office endometrial biopsy is endorsed by the RCOG guidelines as well. And also, compared to other things, what they say is an office endometrial biopsy is the best one, even before an ultrasound. And what do you follow up with an endometrial hyperplasia? You have to do every 6 months office endometrial biopsy. You can't just leave that patient also. Clinical scenarios, this is my earnest requirement, like see these patients and you will know why an EB is necessary. This is about that 18-year-old obese girl with irregular cycle since menarche. By the time a DNC was done, she had an endometrial cancer which was invading the myometrium at multiple places, which precluded fertility sparing option. And she had to have a staging, a hysterectomy at 18 years. So an early diagnosis with an office endometrial biopsy would have saved her fertility. This is a postmenopausal lady with postmenopausal bleeding, which was evaluated 3 years with a DNC. She presented again with repeated postmenopausal bleeding. So again means the patient is definitely not willing for another DNC. So they had to go with a hysterectomy. Post-surgery, it shows a serous endometrial cancer. Staging is not complete. Prognosis uncertain. She lost her chance at sentinel lymph node. And this is another very unusual kind of presentation. A reproductive age woman with a solid ovarian tumor. You do a fertility sparing surgery, it comes as granulosa cell tumor, you're happy. But at follow-up, patients complains with irregular bleeding and has an increased after surgery, and you find on sampling it is an endometrial cancer or an EIN. In granulosa cell tumor, there is always a chance to have an endometrial hyperplasia or endometrial cancer. So when you see solid ovarian tumor in a reproductive age or perimenopausal with a heavy menstrual bleeding, always go for an endometrial sampling or a serum inhibin also. This is another very common scenario where you have a 75-year-old with a 3rd degree UV prolapse, almost ready for a vaginal hysterectomy. She came with a single episode of postmenopausal bleeding. You know, okay, it could be some erosion. You just do a vaginal hysterectomy without endometrial biopsy. Post-op, she was diagnosed. These are all my patients only. Grade 1 stage CA endometrium. So we had to go in for a second lap surgery for removing ovaries and lymph node staging. Again, she doesn't need adjuvant treatment if you do a complete staging, but she lost the chance of a sentinel lymph node. So complete lymphadenectomy and its complications of lymphedema have to be there. This is a 30-year-old morbid obese with history of infertility treatment spanning 2 years. She had irregular cycles which was managed medically, multiple inductions, now with an endometrial cancer. A possible early diagnosis was missed. So infertility patients with endometrial cancer pose a different risk category. They don't, because of the hormones, we cure them with fertility sparing, then they go back, get hormones, again come back with. That is another issue. But yeah, if you have an irregular heavy menstrual bleeding, even infertility, even prolapse, please do that office endometrial sampling as and when you do a pap smear. So what are the other things about endometrial sampling? In Seneca study recently, we have found that significant difference in SLN involvement in patients with early stage endometrial cancer according to molecular subtypes. Nowadays, in endometrial cancer, we do molecular subtyping. So even if you have an information, even before you go in for a staging, you are you have more options. So P53 positive and MMR positive have high chances of having sentinel lymph node positive, but a pole might not have. So if you want to go for a very obese lady, you don't want to go a lymph node and she is pole positive, yeah, that's an option, not a guideline yet. Yeah. So endometrial sampling is a must. There are many things that can go along with endometrial sampling. And also for the selection of patients for ovarian preservation, the integration of molecular and pathological data may improve risk stratification for premenopausal with endometrial cancer to enhance selection for ovarian preservation. If you have a lady who needs preservation, you are more equipped to make a decision if you have a sampling before. and performance of molecular sampling in predicting oncological outcome of fertility. So, molecular classification indicates prognostic value in fertility sparing treatment of endometrial cancer. So, NSMP has higher response rate, whereas you have MMR or P53, you're not very sure about it. So, fertility preservation again with the estrogen and progesterone receptor status, which can be again measured in an endometrial office endometrial biopsy specimen, can tell us about the prognosis and patient counseling. And also, if there is a Lynch syndrome involved, you're not very sure you should go ahead with fertility conservation. You will be able to give a comprehensive counseling that you need a mammogram, you might need a colonoscopy. If it's P53 positive, but not MSH or POL positive as well, you have to counsel them. You're not probably a better candidate for fertility preservation. So there are multiple classifiers where they classify as different. So all these options can be done in an endometrial sampling. So if you decide, okay, I don't want endometrial sampling, I'll just do a frozen at the table. So what are you doing? Intraoperative frozen section is not encouraged for myometrial invasion, not in endometrial cancer, because of poor reproducibility and interference with adequate pathological processing. Histopathological, what you should do is the tumor type and grade should be known in an endometrial biopsy beforehand. You have to do some preoperative mandatory workup. And also, if you know that it is a serous or a carcinosarcoma or an undifferentiated carcinoma, your staging is different. You have to do an infracolic omentectomy as well, along with a lymph node. So that also is an addition. So what are the choices available with a tissue diagnosis to summarize? You have a choice of sentinel lymph node and prevent a total lymphadenectomy and its complications. With the uterus, you can do a sentinel lymph node. After you remove the uterus and you have a diagnosis and you refer the patient, that patient cannot undergo a sentinel lymph node. We have to do a full lymphadenectomy. Ultra staging, which happens only with a sentinel lymph node, that detects 6% extranodal involvement. So that chance also you lose. Preventing intraoperative tumor spillage or tumor rupture mostylation. When you don't have a diagnosis of a malignancy, you're always inclined to pull it out through the vagina. Even if it's a 10 weeks, you might feel, oh, I can just cut it off, mostylate. But you're missing the diagnosis and you are upstaging the patient. So if you do an endometrial biopsy, you have a more focused outlook. Frozen section is obsolete in endometrial cancer. And ovarian preservation decision, as I already mentioned, you can make an informed choice and you can counsel the patient before that. Omentectomy, okay, we already know only 3 of those endometrial cancers need omentectomy. You don't have to do an omentectomy for other cancers. So this option also is. And synchronous presentation of a low-grade endometrial and ovarian cancer. In the morning also I told, when ovarian cancer is glaring at you, you will be tempted to ignore that heavy menstrual bleeding, but don't ignore it. Please do an endometrial biopsy as and when you do a pap smear. That will be it. Thank you.